All right. So I'd like to call this meeting to order at exactly 3:30 p.m. And do we need to do a roll call or have you checked?
I know they just.
Okay. Right. We need to worry about the public or we're going,
Yeah, there's no one in public.
I'll work with the public, okay. All right, take a motion for the approval of the agenda.
Move to approve?
All right, perfect. And then already identified there's nobody from the public. And so I move to the approval of the minutes. We do have to approve the minutes again of the January 22nd meeting because we did not have a quorum at the March meeting. So I take a motion to approve the January minutes.
Move to approve January?
Perfect. Then we'll move on to approval of the minutes for the March 19th meeting.
Approve as well?
Awesome. All right, so Kim came in. Right, then we can now move to old business. And that was, I believe, what we worked on at the March meeting. That we have to go back over again. Is that correct?
Yes. Okay, so we reviewed all of the annual plans at the January meeting. We had all of our participants review them all. They were in the packets. They went to the full board for review. And then we realized that our illustrious board chairman does not count as our quorum when we made the motion. So we are bringing this back to the full committee. We put all of the plans back in the packet for review, so you could see them all again if you didn't remember them in January, so you had a second chance to review them all. So we're asking for another motion to present them back to the full board. So there's a suggested motion in this action item that we will take this again to the full board for its systematics to have them approved by the full board again.
Do I make the motion? Or does one of these guys need to do?
If I may ask a question, I read this 124 pages, whatever.
Thank you.
And I wasn't at that January meeting.
Mhm.
And I didn't have a problem with anything that I read. And did you guys have a problem? Lisa, you recall you did have a problem?
Oh, no, we didn't have a problem. We just
Just didn't have a problem.
thought we had form, but we did not.
Okay, yeah, I moved forward these times before, they did fine.
I think it was just Lisa, me, fair, wasn't it?
Somebody else.
Yeah, it's not. I didn't.
There's three people on there.
We got really confused because I think we also had some board members there that weren't on the committee. Correct. Yeah. That was a long meeting. We went over a lot and it was a shock to find out that none of the county.
Yeah, Jeannie was there. There were some new board members attending just to attend.
Yes, and it was one of the like, first meeting after everybody had shifted around and so, yeah. Second the motion.
Who's the first time? Oh, okay. I think you need to say it verbally.
Oh, for the recording.
Oh, I moved to approve the,
That is,
I'm sorry, the compliance protocols.
I can make this larger if you need to.
Oh, you want to tell us? Just suggest. Okay, very good. I move the quality committee of Bartlett Regional Hospital approve the patient safety and quality improvement plan, infection improvement plan, utilization management plan, and environment of care plans, and forward them to the full board of directors of the Bartlett Regional Hospital for approval. Second.
I remember we also discussed this. This is this quarter's.
Oh, it is? Okay.
Yes, this is, yeah, it's kind of a running, and I apologize, it's also small. So we cleaned it up some from last time, but, we had a total of, 14 grievances in 2026. We cleared them all out except for one. It's been a fairly light month this month, so far, although I have one more to put in. Yeah. So we've got this new system, we've had a total of 62 grievances. Delineated by department and by domain.
Do you see any trends? Is it just? Yeah.
The most significant ones we see, the most of are that come in through the emergency room department. I just think maybe that's the nature of, you know, nature of it, but we see a variety of different, different things from people. We try to jump on them right in time, you know, do service recovery in the moment, so. Rhonda does it and I do it, Michelle's doing it, Gail does it, so. Yeah, but some of them do take some time to research and, you know, figure out what to do, so. I'm happy to answer any questions.
No trending up. It sounds stable or trending down.
Yeah.
Let's get up to this and texting Chris. Jones. It's eight, probably. There's our A3.
While you're doing that, to just discuss a little bit, and I saw Leapfrog up there, and, you know, I've been following a little bit that Becker's, there's been some lawsuits regarding Leapfrog and as, a rating agency, and I wondered if that was going to be pushed into the background, or are they still assessing kind of grading?
What happens with that you see on Becker's is that's for the hospitals that they grade as an F for, and that is the information for, that comes directly from CMS. So that's a lot of the information that is publicly reported to this. And so if you're getting a lot of surgical site infections, catheter infections, and then you can find on Care Compare. So that's straight off. That's not the other information that the hospital. So it is information that they on and look all the hospitals equally. The hospitals that are suing Leapfrog are saying, wait, why are you giving us a grade on this and giving us an F where we're not giving you any information, it's grading us on CMS grades. So that's where it's coming from.
So we're still in the process of trying to increase our grade.
Yes. Yeah, because basically it's looking at the things that we're working on are like our medication safety is looking at when a doctor's putting in an order for potassium, is our EMR looking at the labs and what the last potassium was for the patient? And does our EMR look at it and say, doctor, are you ordering a potassium? Are you ordering too high of a dose based on the labs and things like that? Because we have things in our EMR that helps doctors order the right medications. And right now, we have all of those alerts turned off. So there's things that the pharmacists have to watch and catch. And best practice is in the system is you have some of these alerts turned on that you're not ordering too high of medications based on other data that's in there. So when we went live with our EMR, we had everything turned off and are trusting the people to watch it. And so those are the type of things that with leapfrogs looking at is use your systems wisely. And then other things like hand hygiene, do we do the right amount of monitoring that we're people are washing their hands appropriately, because that's the best thing to help prevent infections. So these are the things that are you self-monitoring and reporting out. And the other thing is, do you have governance level, at the board level, are you concerned about safety? And are you expecting management and reporting up and keeping track of this? And is there board involvement in safety in the hospital? And is there the med staff, are they involved in safety in the hospital? And are they holding management accountable?
It is so dull until something like a fire happens.
Yes.
Yeah, it's kind of good to kind of train that.
Yes, exactly. And it's important. And Chris is here, so we can go to this presentation.
Wait a minute.
You're just going.
Okay.
So,
And you should introduce yourself in case someone doesn't know you,
Sure. I'm Chris Cairns. I'm the Director of Information Systems.
so they can find you in Fred Meyer.
That all of you.
so
Gail asked me here to give you guys an overview of what our current cybersecurity stance is at the hospital and how it has evolved and how the challenges that the hospital faces has evolved over the last year, say. So, sort of useful metric that we can use that's a third-party proprietary source of information, just to kind of get us a size up how we're doing versus other organizations versus other hospitals. It's something called Microsoft Secure Score. So it's a percentage-based metric. There really isn't such a thing as an organization that has 100% in this. It's based upon number of possible interventions that we could be employing versus what we are deploying, right? So that's the percent. So even though like a 53% is an F in the academic world, it's actually fairly decent. You can see the middle box. I'm sorry, I'm a dark mode user, so it's black is right. But our secure score is 53.1%. That is comprised of a couple subcategories: data, device, apps, and identity. Identity is like the usage of a bartletthospital.org address to utilize good software as a service through some sort of cloud-based connection, maybe online storage. Data would be, how much are we protecting the data that we have so that if it were released into the wild, what would our exposure level be of that? What are we doing to prevent things like ransomware? Devices, kind of the type of cybersecurity that most of us are familiar with, antivirus running on end devices. But there's also some like hardening stuff, like simple configurations that we can make to cell phones or iPads and that sort of thing to make them more resilient. And then apps is the exchanging sort of data that we don't actually ever really own. So like this is in the cloud environment between say Cloud Excel and Cloud Word, or data never really belongs to us, but it's used by us. How stern is our cybersecurity stance to prevent any sort of unwanted access there? So those all together are averaged out with equal weight to all of them at 53.1%. The middle, top middle, box shows you what our score is versus organizations of similar size. The similar size means number of licensed users. So we have 1,010 licensed users here at Bartlett. So other organizations that have that many licensed users, which I would say, actually tends toward like the larger end of organizations that utilize this product. So those organizations have a 44.88%. So we're doing slightly better than the average for our size. When you look at healthcare, we're doing way better than the average. So the average hospital in the US that uses Microsoft Secure Score has a 36%. So we're doing really well. But the story that I want to tell you is that there's still lots of work to do, but that the work is getting done. We're improving. I know it doesn't look super compelling on the bottom, which is the timeline of what our secure score has been over time. We jumped 3%. We jumped 3% in response to an incident, which I'm not sure if we're going to talk about that or not, but if you were to pull this out and expand back and see, say, the story of the last 2 years, we're climbing from around 40% up to 53%. And all cybersecurity interventions are really a trade-off between convenience and usability and hardening of the systems. And, in a healthcare environment, you obviously don't want to miscalculate where you're drawing that line between those two things, because it's going to have real serious patient care impact or impact the bottom line. And so these improving any of these areas isn't, like a super fast file. I'm just going to go through this checklist and make all these changes, because it has real world consequences and real world impact to the care that we give patients. So what you want to see is not these huge spikes. You want to see a consistent, steady increase over time. And you do. Probably could have picked a better slide to show that, but I think that's everything I've got to say about this. So that gives you a sense of sort of where we are in, as compared to other organizations. So one of the things on our long range plan is to strengthen cybersecurity, which is smart because the average cybersecurity event breach is several $1 million to remediate. I think it's $3.5 million is the average at this point. So preventing that is obviously extremely important, and it's a moving target because things are always evolving and how business is done. So the long range plan, one of the charges that the strategy 3 owner, which is the IS department, has is increasing our cybersecurity stance for sure. And I got to thinking about why aren't we further along, and that's those sorts of things. And if I may, I'll offer this as a explanation that for most of the time that Bartlett has had like an EHR and a digital footprint, what a cybersecurity risk was a malicious software somehow gets installed on a computer and it ransomwares the computer, encrypts the computer, or data was stolen in some way out of the environment. But it all depended upon some weakness on a device that has keyboard attached and people are typing on it. And so one of the cheapest ways and most effective ways of preventing that sort of thing is you set up these really strong perimeters. So you've got firewalls and you've got devices that are scanning traffic that's traversing through the switches in our network, looking for odd behavior, things that look like ransomware. And you really lock down all of the entries and exits to the network and control access to that, and make sure that that you recognize all traffic that's coming in and going out of our network. Well, as computing has advanced, And cloud computing has really like become more and more of a thing that businesses are leveraging. There isn't this firm barrier anymore between where does Bartlett's network end and the rest of the world's begin? It's a way more hazy concept now. So our email that we were using, that's a cloud concept now. You know, we don't ever store that email here. The email's all stored in a Microsoft server, you know, in Seattle somewhere, and probably replicated across the United States 25 times. And so what I think we, like other organizations, have been slow to realize is that it's no longer enough to rely on making sure that your perimeter's good. And our perimeter is, it's been great. We've really never had an event where anybody broke in the way that you think of, like from 90s movies. But we do occasionally have events where someone steals an identity and they sign into some cloud concept. And that cloud concept can be pivoted into, you know, social engineering attacks where they know specific information about a user because they've now signed in as them, know who they email. And you know, that can, these small things can potentially blossom into like a much larger concern. So what I think we've been doing, and what I wrote in the problem statement here is we have been kind of reactive. So when there's a problem, we say, oh yeah, this is definitely a problem because something bad happened. And so we will remediate the problem, and there's a focus on, you know, the sustainability of that remediation for a period of time. And then we get busy or another problem occurs, and we move off of that and then to the next one. And so what's really missing is an objective framework where we're meeting an objective standard. And there are several different industry accepted objective standards on whether or not you have a good cybersecurity stance or you don't have a good cybersecurity stance. And one of the most well-respected and what is the NIST standard, which is the National Institute of Standards and Technology. Is that right? So what's good about NIST is that it's not so detailed as to be overly prescriptive. It's very philosophical in its approach. So like not, you know, you need a firewall with ACL access control lists that have these particular, you know, ways to think. It's like you want to make sure that this sort of traffic is always inspected. And sort of like what vendor solution you're applying to meet that standard is really up to you and up to the organization and the use cases of the organization, or the budget of the organization. And so that really appeals to me because some of these other standards are very technical, and they're and like the secure score, it's like a percentage, and it's just like it's abstracted away from quality, right? And this is not like that. So the problem is that we just aren't using an objective standard. When we do have cybersecurity standard events that happen, it absolutely crushes our productivity. Of course, when, you know, as I said, the average breach is about $3 million. You know, that becomes that's the most important thing going on. And so we need to know, and we don't always know, the extent of the problem. So everybody stops what they're doing and they all hop on a call, and we work the problem until we know that we've got resolution, or at least the scope of the problem identified. And so, you know, that's another, I guess, good reason to really work this issue, because we got a lot that we want to achieve at the hospital, and so we can't really spare the time devoted to looking into each of these things. We had a NIST audit done recently. So the city of Juneau received some funding through, the Department of Homeland Security, a grant from them, and they got a NIST audit, and they were polite enough to include all of the enterprise funds in the NIST audit. And, so we were also audited, and their results, informed what I wrote here in the root cause analysis. Which is that we largely are doing what we should be doing, but there isn't formality around who owns it, how we do it, and when we do it. So it's really reliant on those group calls where everybody's kind of like talking it through, which isn't necessarily efficient. And so that in turn informs our countermeasures, which, you know, I try to get as explicit as possible. But, you know, really like establishing instances of ownership in different domains. Okay, so like, in the event of a breach, who is the team that's gonna verify whether or not there's HIPAA involved, you know, PHI involved in it? And then if so, you know, who the rest of the organization needs to know. At what point of a suspected breach, are we okay with disabling the ability of potentially like a provider to sign in? And how do we let that provider know? Do we lack those mechanisms to even, you know, we've got a lot of community partners that have identities with us, and we don't necessarily even know who those people are or how to reach them. And so, you know, really writing those things out reveals some of those deficits, and then we can go about plugging those deficits. There's also a PCI element, which is are you all familiar with PCI? So PCI is the regulatory standard for financial data. And it was largely the same. We're kind of doing it, but in a kind of Mr. Magoo. We just are sort of dodging all of the dangers, but it's not real, you know, intentionalized travel. So the intention of this A3 was to be sort of like the master A3, and then there would be sub A3s that would work on each of the areas that are identified. But this one's really trying to tie the idea that the total response and the total cybersecurity stance of the hospital needs to always be in some way aligned with an objective standard, and we've chosen NIST and PCI for our two objective standards. I think that's everything. Do you see have any questions on that high level? Oh, on my A3s, I always include, so for alignment, quarterly, we report out on strategies. And I have a level 2 A3 for strategy 3, which is infrastructure, that has standing KPIs. And they're green if we've met the standard, and they're red if we haven't. And so any of the level 3 A3s that could move the needle on the KPI, I'll put the KPI to the left of the level 3 A3. So you can see that there was a couple of different ones on the top, but anyway, that's the reason for those boxes on the left. The thing that we're furthest along on, and where I think we had the biggest deficit when we first started thinking along formalized lines of like remediating our cybersecurity weaknesses, is identity. And you know, I think about a year ago, we asked the board members all to register for multi-factor authentication, and the intention is that everybody that has a Bartlett identity needs multi-factor authentication. And that was really like the first step along maturing our identity stance. So multi-factor authentication is the will prevent 99% of attacks. Just having that by itself. So it is the lowest hanging fruit, so to speak, with the biggest, you know, bang for your effort. We are at this time, 1 year later, at 100% MFA compliance with all staff. 100% for all vendors and contractors, and about 95% for all of our affiliated credential providers. Those credential providers that are not MFA don't have a cloud identity. We've destroyed the cloud identity. It's on pause, sort of, so to speak. So you can't opt into it. Luckily, none of Meditech doesn't use a cloud identity. It uses an on-prem identity. So it really hasn't had patient care impact. So even though we have a few identities that aren't MFA, they're not exploitable, the ones that aren't. So we're really ready for round 2 on the next best, the next easiest, next lowest hanging fruit, so to speak. And that is that we are going to allow people to not have to reset their passwords. So current best practice is that the complexity of the password doesn't matter at all. When we set up accounts, we say you need to have a password that's 8 characters long, and it has to contain an uppercase, 3 of the 4 of these, an uppercase, a lowercase, a number, and a special character. So 3 of the 4 of those and 8 characters long, and you've met the standard. One, the only thing that matters is the length of the password. It doesn't matter if it's all lowercase. It doesn't matter if it's 12 lowercase a's. There really is no statistical difference in how difficult it is to crack for anything because of the computing landscape now versus 20 years ago when these original standards were. And what we found and what they, studies have done on this, when you force people to change their password every so often, rotate the password, what they end up doing is picking really bad passwords. So they pick stuff that they remember because it doesn't persist forever. So you get into a pretty large constituency of users who end up doing the season and the year. So, every 3 months, every 90 days is about a season. And so you get fall 2026 and then it goes.
We know what she uses.
Yeah. But we should talk to the state of Alaska because they make this change every 60 days.
Well, yeah, and
Crazy.
yes, so we're going to totally stop that. If you are MFA and you are capable of self-service password reset, which will allow people to reset their own password by leveraging all the factors they've got. So they go to a web product site, they hit their multi-factor thing, they then answer their telephone and they can respond to a personal email. You can reset your own password. So if you have that, those two sticks, so to speak, you're compliant with those two. Then the carrot is that you set a password. It needs to be 14 characters, which is long. What we advise usually is like a lyric or a phrase from a book, or I don't know, what was your kid's name? Like, it doesn't really matter as long as it's 14. And it's easy to remember. And then it never expires. And that's actually more secure than forcing 8-character complexity requirements that expire every 90 days. So that's exciting because I think that'll actually really benefit the end user as well. And then we're moving beyond passwords. So the other next thing that we're doing is we leverage a thing for those of you who are in the clinical realm that utilizes proximity badging that'll sign you in on its own. There's another feature of the newer Windows operating systems called Windows Hello for Business, which essentially turns your computer into like a cell phone. So you could unlock it with your face, or you could unlock it with a fingerprint. Those are more secure than passwords or a PIN, just a number that you type in. And we're really trying to be thoughtful about where we can, because, like I said earlier, there's always a trade-off between convenience and security. When we don't gain anything, provably don't gain anything, by inconveniencing people, like, why are you doing it? So, we're trying to create a computing environment here where, there's the least impact to be compliant. So like, the right way is the easy way, is the goal. And let's see, what else do I have here? We've got some work to do in vendor management. So we have historically created accounts for third parties. Say some unaffiliated clinic in town has a clinical reason for needing direct access to our EHR. We'll create them this identity at bartletthospital.org. And then they use that to connect to a Citrix environment or some other way of getting into the network. They access that, sign in for this thing. And that's fine, but what happens is we may never know that that person has left town. They're now living in Montana and they don't need that account anymore. And so we sort of brainstorm, what can we do about that? One of the things we can do is something called guest accounts, where we invite people with using their personal email, not necessarily personal, their business email accounts, whatever that may be, as a guest user. And then if they then lose access to the underlying email, they've lost access to our network. So we don't run into these situations where we have to, have some sort of like direct relationship with HR at our community partners. We don't need to know if there's a direct turnover at the Glory Hall or whatever. That person simply loses access to the Glory Hall's email, they lose access to our system. And so, yeah, leveraging guest accounts is going to be a big thing. And then the last thing is, there's a lot of functionality that happens for automations and such that use identities that don't actually have a human being behind them. And you're not supposed to use the password username for that sort of identity. There are more modern ways of dealing with that. So we're slowly crossing the bridge to get away from the idea of like shared accounts where there's cybersecurity risk to that. There's also auditability risk, like who was actually that person, that account when they signed in, when whatever, occurred. Yeah, so we're slowly maturing our cybersecurity footprint, and if you go back to the Microsoft Secure Score, you can see that where we've gone the furthest is on identity, and I think we still have quite a ways to go in identity, and we'll see a lot of improvement in identity in the next year's time. Following that, we're probably looking at really diving in on the data piece next. So that will allow us to extend the access controls that we enjoy when you're accessing data on campus to off campus. So that, say we want to prevent people from being able to print DPHI, anything but a Bartlett printer. That's totally possible to do that. It's possible to say, well, we're going to give you this thing, but you can't forward it. This is where it ends. It ends with you. So you have access to these files, but you can't then share the files on past that. Any questions on any of this? I'm sorry if I'm breaking.
Good question. When you mentioned a couple of those last couple of things, a couple of those are in place now, correct? Can you prevent it or forwarding? Currently?
We can. So one of the precursors to really firing on all cylinders with that functionality, we have that functionality. It's not really in place for a lot of things because it's dependent on policy. So we need a pretty comprehensive, like, what are the different classes of data? And because I mean, it's going to end up having some impact on workflows. And
Yeah.
But we're in mid, we're working towards that policy.
It's inconvenient when you first come across it, but once you get used to it.
Yeah.
It's, you just know, okay.
And once we have like these more of like SharePoint, OneDrive and some of the more modern that we're rolling out, that people will be used to sharing documents different ways.
I have a question. Did you by chance submit any grants for the rural demonstration project?
Several, yeah.
Okay, that's great.
We're waiting for it. Mid-May hasn't come yet.
Yeah, but that's, I mean, because all the stuff that you've talked about costs money. And so that's great. Thank you.
And then Chris will give us an update in executive session. So this is kind of a segue into his report later. Robert.
Good afternoon. Hope you can hear me okay. This is our board quality dashboard. I think most of you have seen this before, so I'll just run through it. Hit the high points, and if you have any questions, just stop me and we can talk about it. So we want to maintain accreditation and certification readiness, and I believe that currently we're doing that. That's our current status. We want to maintain that. Haven't seen a catheter-related bloodstream infection since 2008. We've improved some on our 30-day readmission rate up to, so lowers better, increasing from 9 to 7.3%. Already touched on Leapfrog a little bit. We continue, our current conditions are C grade, or we continue to press forward toward that A grade. CMS Care Compare quality rating, we are currently at 4 stars. Now, sepsis, you'll note that we've had a significant decrease there. We were running in the mid to high 60s for the last couple quarters. And this quarter, we're down to 46%. We've identified the issue here is, sepsis has quite a few elements that you have to hit CMS's SEP 1 measure to pass the measure. So we passed 13 out of 28. Now, 6 of those fell out because of something called repeat lactate. That hasn't been an issue for us historically, but it is the leader right now. So we've gone to the committees and we've got some order set changes that are in the works to eliminate that, or at least reduce it, so that we would come back. Like, if, for example, if we didn't have those 6 fallouts for repeat lactate, we'd still be in the, I think 67 is what I came up with on that. So we are working, we've identified the reason, and we've got some plans in place to mitigate that. Patient falls. Let's see. Patient falls with injury a little bit lower, without injury a little bit higher. We're meeting our goal in both of those. As far as behavioral health restraints, we had some abstraction issues due to some IT stuff. So that data isn't firm yet. Hopefully it will be next time we present this. Surgical site infection, we had 2 events, so we're slightly over our goal of 0.3 per 100 procedures, currently at 0.4. No catheter-associated urinary events, and no C. diff cases. If you could scroll a little bit, Sharon. The safety culture index and the prevention and reporting, that was part of our 2025 survey, so we'll be repeating that on an annual basis. Our HCAP scores, overall rating for quarter 1 is 74, not quite at our goal of 85. And our likelihood to recommend, we're the same as last quarter, 74, which actually translates, if you look on Care Compare, to 5 stars for that particular category. ED mean time increases, and we normally see this at this time of year. So we're above our goal on that. We've went from 147 to 178 minutes. The next two, safety, culture, resources, and teamwork, pride and reputation. Again, that's part of our annual survey. So you're looking at 2025 results, no changes there. Same with employee engagement and the same with physician engagement. For PFAC, Rhonda was able to leverage Patient Safety Week. She had 5 advisors over 4 days. So a good 90% advisor to staff ratio. So that was a good outcome for our PFAC. OR utilization, we're almost at goal here. This is kind of aggregated between the 3 different OR 1, 2, and endo. So we're not quite at goal, but we've improved dramatically there. On-time start percentage still lag. End of first quarter, 21%. Goal is 60. And our CDI, we don't have any data here because Jeanette and her team are fielding or have already implemented a new software program. So there's been a lag in that. And hopefully we'll have that established soon. Did anybody have any questions?
It's going to stand for our party.
Okay. We have a couple of changes since the last time we looked at our dashboard. I won't go like line by line because some of those are just kind of will be static until the end of the year. We did see a little bit of movement downward, which is positive in our quality measures once. So Sharon, if you could just scroll down just a hair. We don't have any major process improvement plan related to these 3 measures. I just wanted to keep an eye on them because they had flagged on kind of like high percentile rating for our facility. And now that we have Kathleen on board, who's our MDS nurse, she looks at this stuff monthly. And so at the resident level, so we have been looking at it more at the resident level, which is really great, kind of getting a feel for how the measure works. We're a very small number. So, these percentages you are looking at, involve just a small amount of residents. But glad to see it going down just a little bit. And then I just wanted to note, Sharon, if you could scroll down a little bit further. So our average daily census dropped Q1 related to the snow damage and the water leaking in the facility. But just a little preview as of 1 o'clock this afternoon, our census is at 57, which means we have one resident in every single room. So I'm very excited about that. We have some discharges coming up, but we've got some referrals and admissions coming up to all of that. So pretty excited about that. Is there any questions related to the dashboard?
I just want to say the percentage of residents who lose too much weight, that's a significant drop. That's right, because it's an inverse measure. So going from 14 to 9, good job.
Yeah. And our dietitian has been meeting not only just doing the work with the clinical staff, she's been meeting weekly. I know at least the last few weeks, not more, with the home attendant group, and that's the group who actually serves the food, doing education. So we've been kind of on pretty hard.
Because that's really important. It's going to help your pressure ulcers and quality of life for your residents.
I also just want a quick shout out to Rhonda. Every time there is a fall incident at work, she is over there the next day before sometimes I even know what's happened. Really appreciate that support, Rhonda.
Thank you, Deb. We're trying.
Next one.
So this is looking at our workplace safety. So I know it's super small writing on there, but there's just a couple that I want to highlight. So this is broken up into 3 sections. We have verbal instances, physical, and then what I look at is kind of like a miscellaneous or just a general environment safety. So the top looking at verbal instances. So again, these would be ones that there was no physical harm, no restraint, anything like that. The two I really want to look at is the top two. Looking at locations, we have emergency services at the top. Our goal is 20, and as of Q1 2026, we are at 16. So we are getting really close to that goal already. And so also with behavioral health services, our goal of 10, and we are already at 12 at Q1. So those are the two big highlights there that I wanted to point out. And then the last was also professional conduct, which is under the verbal instances. So this is how we work and communicate and talk to each other. We're at 10 so far. Our goal is at 20. So looking at a positive side of that, we have gone down since Q4 2025, which was at 16. But those are the three big highlights that I want to point out. For physical incidents, looking at the emergency services and wildfire court were the only two that were technically trending up, even though those numbers are still very small. Then looking at the environment safety, the traffic and speeds, which I know has been an ongoing thing with security to try to crunch down on that. We Q1 saw 0. Granted, with Q1, with the snow and stuff we had, there is a little asterisk with that. But with the ED remodels going on and the traffic revisions we've been having, I see that remaining low. JPD calls to campus. From the reports that I had, we had one. I am following up with our security manager to look at that because we've had quite a few. However, we need to look at why they were called. A lot of times they are having someone in their custody and they call another JPD officer or something like that. And then other damaging events or safety, we're at 4. Our goal is 0, but with that one, it's kind of again a miscellaneous catch-all there. So.
Do you want to review the medication?
Yes. Can everyone hear me okay?
Yes. Yes.
Okay, thank you. First of all, I know it looks like we've had a lot of medication events, but we really try to encourage reporting on a wide variety of anything related to medications. That could be computer errors, it could be delivery late of medications, it could be the Omnicell issue. So it looks like a lot, but we really do want to encourage a lot of reporting so that we can identify different errors that we might be able to fix. A lot of the errors in event reporting has to do with alerts like what Gail was mentioning earlier for Leapfrog. The electronic health record and the barcode medication scanning should actually help make our medication administration safer, but we do not have everything turned on. We do a really good job in a couple different areas, and that would be identifying inappropriate medications that potentially can interact for especially the elderly. But other flags and alert, we don't have them turned on, as she said. So the medication events by department, the highest one is Med-Surg, because they really do have the most inpatients and the most medications per patient of the hospital. But as far as medications by seriousness, the most serious events are associated usually with ED or CCU. The medication scan rates are doing fantastic. We have a process improvement project going on in same-day surgery. So, so they're working on that. The good catch for medication events could be a little bit higher, even though we've had some improvement in that. But we really want to encourage that reporting. So even though it's improving, we want to go even higher next time. Anything I can help like delve on specifically that you guys would like to know more about?
The wrong patient concerns our department that doesn't use scanning. So that's one thing. In our mental health unit, they don't wear bands, or they swap out bands, patient bands. So with our new interim, she changed the practice that every single medication administration record has the picture of the patient there, and has instituted a new practice up there. So I'm hoping next quarter that will be 0, because they were going by memory or asking the patient the name, which may not be the best practice. So.
Yeah. And another thing I was going to say, we did have a couple medication related successes. And one would be the pediatric double check hard stop for the medications in the same day surgery. And then also in the emergency department, when they send patients home with medications because pharmacies are closed after hours, it used to look like we administered the entire packet, but now that has been fixed also. So through tracking of these incidents, we do try to do process improvements, and we have been making some headway.
Yeah, our interim pharmacy director is working really hard on making changes on things, so.
I noticed that the wrong dose rate is up. Is there a specific issue that you're able to identify for that?
The what I seeing for those cases, usually it has to do with tablets that might have to be cut in half, or an order that actually did not get caught up with a decreasing dose or increasing dose. So those are the most common dose related issues.
Okay, thank you.
Okay, Q1 for my compliance report, you're gonna see some things that are not up to date on our compliance dashboard. So our code of conduct, we ended the year high on our attestation. Our physicians were still catching up on some of our physicians that were sent out at the end of the year. So right now we're sitting at about 78% of our physicians having it. All of our new physicians attest to their code of conduct upon hire, but we sent it out again to all of our physicians. So we're still catching up on that. And then policies right now, we have a total of 6 new and revised. I'm currently up to date on where we need to be on our revisal. Most of them are coming due about September. So that is currently right where it should be. Our exclusion screening, you will notice that there are some zeros here. When we went from Meditech over to next week's, we broke our process. And when we went from API or yes, right, to UKG, we broke our process because we had nice reports that were coming out, and we were able to do our monthly screenings. So we're now having to pull reports differently, and we're getting back on track. The only thing that was working 100% was the physician screening that came at a credential screen. for our doctors on a monthly basis. And then the other one that, was the vendor screening that was coming out of, Meditech for our vendors also. So
We've got
we got-
reports,
we're working on it.
yeah, I submitted for April.
So, yeah, so we're catching those up and that will, by next quarter, we'll be back up to 100% on that. Education, new hires are at 100%. Our annual compliance HIPAA training for employees are due at the end of the year. And so we're good there. And then our compliance investigations, we did not have any hotline calls first quarter. We had one, just on this second quarter, so I just put it in there for keeping me on track for the next reporting. We've had quite a few issues that have come in compliance, as you can tell. My biggest concern being reported this quarter actually is retaliation for a couple different inside group departments. We've been doing a lot of investigations with HR on what retaliation means. Most people think retaliation means working with other employees. The definition of retaliation means that it has to be someone who can control your schedule, your workflow and that, and they're talking retaliation, amongst coworkers, which really is not a definition, that falls into a hostile work environment. So that's a lot of what I've been working on. So we have had a few cases that do meet the definition of doing an investigation was retaliation, but those are the issues that came up this quarter. I did not get the claims and billing from Tammy right now. She is deep into a couple of audits. So I did not get that information from her, but that'll be on next time. And then the concerns that went to HR for compliance, we had 2 people who let their licenses lapse and did not, had to take time out of work until they got that renewed. Background checks, again, they had to take time off until they got their background checks up with 6. Hostile work environment with 5, retaliation 2. And then work requirements, that is the education, the requirements that they have to keep for their job is 75 people. Were going to HR to make sure that they kept that up to date to manage their work. And then this is the repayments and overpayments. We will have that on for the next meeting for you. Okay. We can just keep going. What we're going to do on each, okay, scrolling, that's just definitions. Everything. What we're going to do on each of our meetings now is we're going to add a leapfrog moment. Joe is wanting to continue our leapfrog quest. So this month, Rhonda and I are going to be talking about board responsibility. This also fits in with our PSSM, which is our patient safety structural measure for CMS that Robert had just put in and attested to for us for CMS. So when we talk about board governance oversees patient safety, which means everything that comes with patient safety, with overseeing the med staff and the quality of patient safety within the hospital rolls all the way up to the board, and it's oversight by the board. So this section that Rhonda gave me, and she's been working extremely hard on the leapfrog information that we have to send and attest to every year. This is for what is required for the board to know and the senior leaders and the CEO. So this is one that she's looking at is within the last 12 months, the senior administration leadership has taken a direct action. So this is looking at the CEO, is enforcing patient safety, so doing walkarounds, and what is he reporting to the board? So this is the one thing that when you talk about the board's 8.3, and when you're talking about in governance, is how are we involved in the hospital? You know, how are we being seen? How are we looking at and involved in what's happening in the hospital? And the other part of that is, I thought was very important, is when you're talking about how are we measuring the effectiveness of our CEO. I was really pleased to see that one of the KPIs of measuring him on what is he looking at for quality of care, and what KPIs were you putting down? You were looking at patient satisfaction, patient, safety. So these are the type of things that Leapfrog is looking at and the PSSM measure is looking at. So these are the type of things, is it on his calendar? Is it on Kim's calendar, my calendar, Angela's calendar, Chad's calendar? So this is the type of thing that Rhonda is coming around and saying, okay, show me your calendar, show me Joe's calendar. Are they making it out to the units? And is the board holding us accountable for it? Look at the next slide. And then the other thing is looking, I know you all know Charlie, IP guru, is looking at our hand hygiene data. So we all know hand hygiene is the way to prevent infections. So are we reporting it up through to the medical staff executive committee, to the med staff committee, to our nursing leadership, our senior admin, and up to the board? So, are we having, and I think Joe might, before I even presented this, I think he already has it scheduled for Charlie to come and talk to you all. So, are you getting that data of how is the hospital doing, and what is Charlie being given the resources that she needs for the hospital to do her job? Because you actually oversee the infection control program, and in her role, she's appointed by the board. I don't know if y'all remember that, but you do appoint her as the IP specialist. So that's the things that in our Leapfrog that we are actually attesting to. And you can say, this is where Rhonda has to go in and say yes or no. Do you do that? And we have to say yay or no. Okay, and I think that was it, or did I have one more? I think that was it. Oh, my quote. Yeah. So, culture. This is it. So this is our culture. Oh, sorry. I loved hearing Warren Buffett talk when I lived in Sun Valley. He used to come every summer. And it's our culture. So we determine at the top what kind of culture we want to have at Bartlett. So we lead the culture. Anything you want to add to that, Rhonda?
I was actually going to say, Leapfrog, as far as accountability, they want documentation of almost everything. So just by having some of that at this board meeting, the next time we answer, I'm hoping to be able to answer yes. That no on the last slide was from the last November submission, and we submit every 6 months. Thank you.
And she won't let me say yes unless I have it documented somewhere, like a board meeting or minutes. She doesn't just say, let me say yes to
Yeah,
anything.
you have to say yes to everything in that, or you have to answer no. So if you don't give it to the med staff and ZAC committee, but to give it to the board, you have to answer no, unless you can produce a document if Leapfrog asks for that data verification. So it's very, they are very strict.
Here's my document. Okay. All right, so now I just need, I'm gonna take us into executive session.
I move the Quality and Compliance Committee of Bartlett Regional Hospital to recess into executive session, to discuss legal updates.
Second.
I'm going to stop the recording. I move the Quality and Compliance Committee of Bartlett Regional Hospital to come out of executive session and return to the regular meeting.
Second. Spell
Any committee comments and questions? No. All right, we are adjourned. Thank you.
Thank
Thank you, everybody.
Email around when we get together next.
I think it's like 2 months from now. I think you said it.
Yeah.
Yeah, I think it's the same day, same time. I think it's works unless you